The following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by independent educational grants from AstraZeneca and Johnson & Johnson.
Hello, and welcome to another episode of the AUA University podcast. I'm your host, Dr. Mark Gonzalgo, Professor of Urology and Chair of the AUA Office of Education. Today, we're diving into one of the most rapidly evolving areas in urologic oncology, the treatment landscape of muscle-invasive bladder cancer. If you've been in practice for more than a few years, you've witnessed a profound shift from chemotherapy-only paradigms to immunotherapy, antibody-drug conjugates, and now increasingly biomarker-driven and molecularly selected treatments. Today, we'll walk through perioperative systemic therapy updates, neoadjuvant and adjuvant strategies shaped by Niagara, EV303, and Checkmate trials, targeted therapies and mechanisms of action, emerging sequencing principles, and practical management of immune-related and targeted therapy toxicities. And importantly, we hope to translate all of this into clinically usable takeaways for everyday urologic practice. I'm thrilled to be joined today by Dr. Jen-Jane Liu, Director of Urologic Oncology at Oregon Health and Science University and the Knight Cancer Institute, where she leads clinical, research, and multidisciplinary efforts to advance the care of patients with bladder and upper tract urothelial cancers. Her work spans clinical trial development, perioperative systemic therapy integration, and optimizing cancer outcomes through collaborative team-based care. Dr. Liu is recognized for her expertise in the treatment of patients with urologic cancers, and particularly for surgical and biomarker-driven personalization in urothelial cancer. Jen, we're thrilled to have you here today. Thank you for joining us.
Thank you so much, Mark. It's a pleasure to be here.
So let's start at the beginning, localized disease. The Niagara trial really reshaped the standard for cisplatin-eligible muscle-invasive bladder cancer. Can you walk us and the audience through the key findings and why gemcitabine cisplatin, or GemCis, plus durvalumab has become a new standard of care?
Yes. So in the prior situation where you had a patient who was platinum eligible, they would get GemCis or MVAC alone prior to cystectomy. And the Niagara trial essentially used the GemCis paradigm and then randomized half of the patients to also receive durvalumab, both in the neoadjuvant setting, so prior to surgery, and then also for, in total, about a year after surgery in the adjuvant setting. And what they showed was that in patients who had localized or N1 node positive disease was allowed, that there was an improvement in both event-free survival and also overall survival when the addition of durvalumab was used in the regimen. The total response rate, so the PT0 rate, was 37%, which was also higher than in the GemCis alone group, where it was 27%.
Great. And they, I believe, had similar adverse event profiles, right, between the two groups?
Right. That was an important aspect of the study to show that the addition of this extended period of immunotherapy did not result in an increased number of adverse events or delay or prevent patients from getting to surgery.
And you know, it's interesting because as we learn about new treatments, really it happens very frequently. What in your opinion has become the role of historical treatments such as MVAC, or the relative contribution of neoadjuvant versus adjuvant IO?
I think that's a great question and one that is still controversial. So per the NCCN guidelines, both GemCis durvalumab, as per this trial, and Dostent's MVAC remain options for first-line therapy in the platinum-eligible setting for neoadjuvant treatment. And I think that's because there remains level 1 evidence about the survival benefit with MVAC. And I think the sandwich approach that they used in Niagara, where they were giving the durvalumab both pre-surgery and then also in the adjuvant setting, calls into question what was the relative contribution of the immunotherapy in both settings, because we know that adjuvant immunotherapy, when given after chemotherapy alone, can also enhance survival.
Great. And, you know, keeping on the subject of neoadjuvant therapy and now shifting gears to cisplatin ineligible patients, right? For the 40, say to 50% of those patients who don't necessarily meet Galsky criteria for cisplatin, the EV303 trial, I think, has also been practice changing. What should urologists know about EV plus pembrolizumab in the perioperative space?
Yes, this was a very exciting trial because there are a large number of patients with muscle invasive bladder cancer who may be candidates for surgery but can't get platinum, as you mentioned. And so previously, these patients would go straight to surgery, and we knew that their outcomes were not as good. And what EV303 did was it was actually originally a three-arm trial, but the two arms that were ultimately studied were going straight to surgery versus getting enfortumab vedotin plus pembrolizumab prior to surgery. And they showed a really impressive overall survival benefit with 80% of patients who received EV Pembro alive at 2 years. And the PCR rate was also very impressive, 57% versus 8% for those that proceeded directly to surgery. There was, to temper some of the excitement of those results, there were pretty significant adverse events. Over 70% of patients had a grade 3 or higher adverse event associated with this treatment, although only 4% of patients had surgery delayed as a result of these, and the surgical complication rate was similar between the two groups. So some of this high adverse event rate could be in large part due to the surgery itself.
Great. So again, I think again, exciting options now for those patients who were previously ineligible for a neoadjuvant treatment in this space as we continue to learn more about evolving treatments. You know, I wanted to talk now about options after radical cystectomy. So we're talking now about adjuvant therapy. You know, after cystectomy, we often wonder who are the right patients for adjuvant immunotherapy, and how is ctDNA or circulating tumor cell DNA beginning to reshape this conversation?
Yes, I think this question has become a lot more complicated, in part because of these new neoadjuvant regimens that incorporate immunotherapy. So, originally, when we were still doing chemotherapy in the neoadjuvant setting, for patients who had residual muscle invasive or node positive disease at cystectomy after receiving chemotherapy, or if they weren't able to get neoadjuvant therapy and just had locally advanced disease, T3 and higher or node positive, then we tried to give them some type of adjuvant therapy. And that could come in the form of chemotherapy if they were eligible and hadn't already received it, which is a very small population. Or the Checkmate trial showed that nivolumab in the adjuvant setting enhanced overall survival and decreased death by about 30%. And so that really became the standard of care for patients with sort of high risk disease for recurrence after radical cystectomy. Now that immunotherapy is being bundled into these neoadjuvant regimens, it remains to be seen how it will continue to be used, since most of these regimens have sort of a sandwich approach where you're automatically giving the immunotherapy adjuvantly. As for your question about circulating tumor DNA, that is a really exciting area. When we think about adjuvant treatment, we know that we're trying to prevent disease recurrence, but along with that, we are also over-treating a significant number of patients and exposing them to the side effects of these medications. And so we know that ctDNA can basically help predict patients that will recur, and it can do that more quickly than conventional imaging technologies. And so there are a number of new studies and trials that are designed to sort of see if we can leverage circulating tumor DNA to help drive these adjuvant choices.
You know, it's interesting because obviously patients are always trying to seek options, some of which are not inclusive of cystectomy to try to avoid the morbidity of that procedure. And you know, that's where things such as trimodality or radiation approaches come into play. Before we move on, Where do you feel that chemoradiation and IO-RT combinations stand today?
So for now, IO and RT in combination are mostly being used in a trial setting, which seems appropriate. There are some theoretical advantages of immunotherapy, one of them being the abscopal effect, where the release of tumor antigens may enhance the response to both chemo and radiation therapy. But for now, it's mostly being used in a trial setting. And the standard of care for chemoradiation for patients who are good candidates for that and with muscle invasive disease remains using some type of sensitizing chemotherapy regimen. Common ones include GemCis or carbo or mitomycin and 5-FU, followed by radiation.
Great. And, let's talk about what happens now after the perioperative period, when you're following these patients. Dr. Liu, what's your approach to surveillance? And when do you pursue, for example, rebiopsying or molecular profiling when appropriate?
So the good news is because these new neoadjuvant therapies are fairly effective, we are improving the survival. But we do know that bladder cancer is still a deadly disease and incurable when metastatic. And so we do still need to carefully watch these patients for recurrence. That typically involves cross-sectional imaging and considering more advanced imaging if indicated. But if you do notice a recurrence, it is a good idea to go ahead and biopsy that, even though it may seem obvious that that is a recurrence of the parent's metastatic disease, because molecular driven therapies can be used in these patients in the metastatic setting. And you may identify a mutation that enables the patient to get one of those treatments. It can also help identify clinical trial opportunities for these patients. Circulating tumor DNA is being used in this setting, although it's not necessarily validated. Many of the retrospective studies suggest that it can show recurrence of cancer with a lead time to conventional imaging and can be tied to prognosis and potentially even used as a monitoring marker for response to treatment.
Great. I wanted to move on and kind of shift things to treatment now to more advanced disease, specifically metastatic disease, and try to put things in historical context for the audience. Before we talk about, say, first line EV Pembro, I think it helps to remember where we came from. Can you summarize the cisplatin carbo era for the audience?
Yes. So when patients had metastatic disease, it was and still remains mostly incurable. And chemotherapy was really palliative for to extend life. And we know, as you mentioned, that 40 to 50% of patients are not eligible for platinum. So while gemcitabine, cisplatin, and MVAC were sort of the first line therapies, most patients couldn't receive those. So they would often receive carboplatin, which is decreased efficacy. Um, and so, knowing that most patients aren't eligible for this, the change of having EV Pembro available, which doesn't require patients to meet the Galsky criteria, has really been a game changer for patients to be able to have treatment when they're not platinum eligible. So EV pembrolizumab has been shown to increase survival and extend survival in patients with metastatic disease in both the cis eligible and cisplatinum ineligible population, with response rates between 65 to 72%, which is very good and better than chemotherapy alone.
Great. When considering chemotherapy plus immunotherapy, two early pivotal shifts were Checkmate 901 and the Javelin trial. How should urologists think about the role of, say, maintenance therapy today?
That's a great question. There are still some patients who, because this treatment landscape is changing so rapidly, would have received just chemotherapy in the first line metastatic setting. And Javelin and Checkmate both showed that in the Javelin study, that after completing the chemotherapy regimen, that avelumab, so immunotherapy maintenance, was well tolerated and extended overall survival. And in the Checkmate 901 trial, the addition of nivolumab to gemcitabine and cisplatin regimens for metastatic disease showed a better response rate compared to the chemotherapy alone arm.
Great. I think other potential therapeutic combinations, ADC plus immunotherapy, I think is where the field is perhaps evolving most rapidly. EV plus pembrolizumab is now an acceptable first-line treatment. What do clinicians need to know specifically with regard to outcomes for these patients, whether they're cis ineligible or eligible?
Well, I think that patients that get these drugs there's a high response rate. And in fact, in the EV studies, there was even a complete response rate of somewhere between 15 and 30% in patients that got these drugs. But there is toxicity associated with them. So enfortumab is still, in a sense, chemotherapy, even though it's an antibody drug conjugate. So basically, the mechanism of action is that it's an antibody to nectin, which is highly expressed on urothelial carcinoma. And it contains, tagged to that, a chemotherapy payload, essentially. That's a microtubule inhibitor. So these patients do still experience side effects, even though the drug is more targeted than sort of the blanket cytotoxicity we would see with GEM-CIS.
Right.
And that does result in a side effect profile.
Yeah, you talk about now moving gears to molecularly targeted agents. Once we move past first line treatment, the biomarker story perhaps becomes even more important. I don't know if you have any comments on this with regard to the various agents that are used for those who are listening.
Yes. So I think that biopsy of metastatic sites, as I mentioned previously, has become more important because of this biomarker or mutation driven treatments. So, second line, there are a lot of options. And one of the drugs that we use for patients that have a mutation in the FGFR receptor, which is not an uncommon mutation seen in metastatic urothelial carcinoma, is erdafitinib, which is an oral FGFR inhibitor. And patients that have an FGFR3 mutation are eligible for this as second line therapy. Um, there is also sacituzumab govitecan, which is another antibody drug conjugate that targets TROP2, which is a molecule highly expressed in urothelial carcinoma. And trastuzumab is another antibody drug conjugate that's a topoisomerase inhibitor that's been shown to have efficacy in patients whose tumors overexpress HER2 on immunohistochemistry. So you can see how the biopsy can be important in selecting a second line therapy in the event that your patient has one of these alterations. They may be eligible for these targeted drugs.
Great. I wanted to also move gears to practical NCCN aligned sequencing strategies. So for those urologists perhaps who are listening to this podcast on their commute, can you summarize kind of the practical sequencing framework that we should be following today in terms of first line and second line options?
So for metastatic urothelial carcinoma, first line is enfortumab vedotin plus pembrolizumab for all comers. Alternatives can include GEM-CIS or MVAC, so chemotherapy-based regimens, plus or minus an immunotherapy like nivolumab, or switching over to avelumab maintenance. That's first line. There, in the second line setting, it's highly recommended to consider a biomarker-directed therapy. So, erdafitinib for FGFR3 mutations, trastuzumab for HER2 overexpression, and then there's also sacituzumab, which is the TROP2 antibody drug conjugate. So there's a lot of different options, and what's available to you second line may be affected by what the patient has already been exposed to in the first line, whether that be chemo, an antibody drug conjugate, or immunotherapy.
Yeah, great points. And with each of the new agents, we've kind of hit the subject of potential side effects, right, or adverse events and toxicities. And a lot of these now are specifically immune related. And I think one of the most practice changing aspects of this new era is toxicity recognition and management. So if you could, I guess, at a high level, perhaps do an approach to demystify some of the immune related adverse events and, basically what do urologists need to know?
Absolutely. In the past, we were kind of used to seeing what chemo did to patients because they got it before surgery and then we reevaluated them and saw what happened. With immunotherapy, with immune checkpoint inhibitors, the side effects are totally different. And even I think the medical oncologists have taken some time to sort of understand and process. The important thing is recognition of these toxicities because they can essentially affect any organ system because of their mechanism. Some patients may never get them. Some patients may not get the same one if they're rechallenged. They're dose independent, which is also kind of unusual compared to chemotherapy toxicity. And many patients will actually need more than just supportive care. They may need suppression with steroids to actually get through this immune-related adverse event. What we know is that up to about a third of patients will experience these immune-related AEs. The most common organ systems that you see will be dermatologic manifestations, musculoskeletal, like polymyalgia rheumatica type symptoms, and hypothyroidism. Those are the most typical. Rarer but potentially fatal immune-related adverse events include colitis, including bowel perforation can occur, pneumonitis, and myocarditis. And that's why early recognition of any of these side effects is really important so that the patient can stop therapy and then start high-dose suppressive steroids to help mitigate the effects.
Yeah, no, I think these are all great clinical reminders, especially as more urologists begin to co-manage and follow these patients alongside medical oncology. So Jen, before we wrap up, let's distill this into 3 high-impact takeaways for busy clinicians. I don't know if you could do that for us and try to give us your best summary of what was covered today, not only in terms of the perioperative treatment, but also maybe for the metastatic disease state, as well as the last section which we commented on, which was toxicity recognition.
Absolutely. So I think for patients with muscle-invasive bladder cancer being treated for curative intent, that perioperative therapy is now based on chemotherapy plus immunotherapy. The Niagara trial has really established gemcitabine, cisplatin, and perioperative durvalumab as the standard of care for patients who are platinum eligible, and enfortumab vedotin plus pembrolizumab for those that are platinum ineligible. In the metastatic setting, I would say that EV Pembro is the standard of care and potentially consideration of maintenance immunotherapy where appropriate, and that's for all comers. And the last point would be that toxicity of immunotherapy is real and can infect a lot of patients, and that it's very important to have early recognition that this can affect any organ system so that patients can stop therapy and potentially undergo treatment to mitigate the potential dangerous effects of this overactivation of the immune system.
Great. Dr. Liu, thank you for an exceptional discussion. This is the type of practical, high-yield insight that helps urologists navigate an increasingly complex landscape. And thank you to our listeners for joining us on AUA University. For additional educational resources, guidelines, and upcoming programs, visit auanet.org/university. We'll see you next time.